today mitral TEER with the PASCAL device, and I'll do with case with Hakkı Şimşek, and also we have very important guest to me. We have Michael from Greece. He's a very good friend of us. He's a perfect expert echo guidance people, and hopefully we will hear some lecture from him after the case, and he will guide us, and I'm very happy to have him in my lab. Actually, he's very, very good. So let's have a presentation from Özge.
Good morning, everyone, again. Now this is a mitral regurgitation case. The case is a 67-year-old female, and she has severe dyspnea with a functional status of New York Heart Association Class 3. She has been suffering from some hemodynamically unstable episodes of paroxysmal atrial fibrillation, and she has also suffered from recurrent episodes of pulmonary edema. She has chronic kidney disease, and she is taking peritoneal dialysis for the last 3 years, and actually 4 times per day. And she had also a previous PCI to the LAD diagonal one bifurcation 1.5 years ago. And her echocardiography, I will show the images, TOE images later on. And she's during the physical examination and ECG check, she had the sinus rhythm on ECG, and she had also a surgical valve repair her estimated STS score risk factor was 15, and estimated Euro score 2 risk factor was 11, which is high. And the heart team decided on the PASCAL intervention transcatheter edge-to-edge repair. And let's see the images now. This is the long axis view, 2D views. And you can see that the ejection fraction is low at around 30%. She has segmental wall motion abnormalities, which is consistent with coronary artery disease, LAD, and diagonal disease. And you can also appreciate the tethering of the valve, this is a functional ventricular mitral regurgitation. Let's see the regurgitation images, and you can see it feels almost 70% of the left atrium. And she has also a mild aortic regurgitation. You can see it. Let's see. And those are the 3D images. And on the right side, you can see the 3D ANFAS view of the mitral valve. In the middle, there is a small coaptation defect due to the enlarged left ventricle and also left atrium. And on the left-hand side, you can appreciate the treatment as it's a functional one. This is the mild to moderate tricuspid regurgitation. This is the 3D measurement of the mitral valve area, and it's around 4.5, which is greater than 4 centimeters square. And this is the mean gradient on the valve. It's 2 millimeters of mercury, which is also good, less than 5. Yeah, those are our images. The word is yours. Thank you.
Okay, thank you very much, Özge. So you solved the case. Actually, I will ask Michael to show us the what we have today, and then of course before we start, it's nice to have a good plan if we implant 1 or 2 PASCAL here. So could you show us how large MR we have? I think we have a quite large MR.
So good morning, everybody. And here we see a biplane view of the left ventricle. We see it's a dilated left ventricle with global systolic dysfunction and ejection fraction visually estimated about 30%. We see here that the ventricle is dilated with impaired systolic function. We see here that we have a commissural view with color, and we have a wide color of regurgitation, which we measured later on about 20 millimeters in vena contracta width, at least. Here in biplane imaging as well, we see that the jet is central. It seems to be symmetric tethering of the leaflets and centrally directed jet into the left atrium. Here we have the similar image as well. A very wide jet of regurgitation from all across the central part of the valve, across the A2, P2. We see here an estimation of the PISA, which we do later. Here we did the transeptal puncture. We were able to cross at a level of about 4 centimeters above the annulus plane. These are our initial attempt, but here we're going to go to the final attempt here.
The first one just was, true PFO, and it was a little bit actually lower. We don't like it. It was 3.3, so this is the final position. This
Mitral valve and fast view, and we can see that there's no clefts or indentations, and we get a sense that there is some malcoaptation, generally speaking, at the center of the valve, and we can see the color here originating from the central area A2P2. It's a very wide jet. We had some flow reversal in the pulmonary veins. We have an assessment of the vena contracta area. It's about 21 millimeters across the bicommissural view. We advanced the steerable guide into the left atrium.
Strategy, Professor Göktekin, to use two device or large device, only one large device?
Okay, yeah, Ismail, hi. So I think I'd like to have your opinion as well, but if you ask our opinion, we believe that we have to use two Pascal here at least. Yeah. So So we don't have an issue of material analysis. It's quite large. I don't think we will have a gradient after 2 Pascal here. We don't think so. We will see. But I think even we use Pascal P10, which has a spacer, we think that it may not be enough. So we will put one Pascal a little bit medial, and then next to it a second one. That's our plan. The first one will be, I think, P10, and then second one will be most probably ACE. We will see. So yes, it's our plan. What do you think? So yeah, any other thought? I think we all agree. Are we all agree to put two device here?
In my opinion, I would always try to do one try, and then you always have the possibility to change to two device therapy. But in this case, the jet is so wide, so most probably you need two devices. But I try first one Pascal ACE in the middle, look what happens, and I often have a surprise and everything is gone. So maybe this could be a strategy too. You can always change to device strategy, then you can solve it, go more medial, and then put one lateral. Sometimes you have in the middle of the devices a leg, and this you never can be able to close. So always try one
even
device.
Dursun, even this patient, you mentioned yesterday that you always start with the like you do first device, and I think you will do the same. I think that's important experience. So if we use first only one device, which would like to use? Is it ACE again or P10?
I would use ACE. In most cases, I use ACE.
Okay, right. So any other thought? I think, Michael, what do you think regarding this? I'd like to have your opinion too, because you have quite a big experience.
Yeah. Obviously, we always try to use a single device as possible, even in cases that appear from the beginning that most likely they will require two devices, but we always try with the first device to do the maximum effect. In patients with functional MR, we often try to use the wide Pascal device, the P10. We use ACE as well, but many times we use the P10 because it's a wide device, has a spacer, and in particular cases like this where it's a very wide jet, we'd like to utilize the width of the Pascal P10, which is 10 millimeters, to get the maximum effect as possible. Again, we can also use ACE, ACE and ACE and see what happens. And again, we will try one in the middle, see what the effect is, and depending, we can reposition or put a second device next to it.
I think, I mean, I have a good experience from Macha Clip, but this is my third case with Pascal, so we are still learning the Pascal device, to be honest with you. I want to ask you, Ismail. Ismail, tell us. I'm a little bit in between now. Start with one clip or start with two at the beginning. What's your suggestion?
Maybe based on the experience, your experience about the mitral clip, that's why similar device, especially PASCAL Ace, starting PASCAL Ace, it will be logical, I think.
But the thing is, you have a spacer P10, so it has a space and then it's larger. That's why if you put, because Michael is suggesting us to put P10, yeah, with space, so it's I think we have more chance to finish this case with the PASCAL spacer one, which P10. That's why I'm a little bit in between. If I would do this case with mitral clip, I will start in my practice with two clip, to be honest.
I will start PASCAL Ace and direct to the over the jet, and I will see what will happen. Sometimes, surprisingly, one clip, even this kind of jet, you can eradicate whole jet. That's why we start and we will see what will happen. Also, thank you for very good case choosing, especially supply all co-opt criteria. This is very good, very good case for
All
this
right.
process.
Okay, guys. So anyway, so we combine your thought because really, I mean, we decided. I don't mind to decide this case together. You know, I don't mind it. So, but we will put a spacer, PASCAL with spacer, and then we'll see if it is works for one device or not. Yeah. Okay. Let's see. So now we did. Yeah. Let me work a little bit, and then meanwhile we can talk and I can answer you. So and now I am inserted already our device, and so I'm pushing now. Yeah. I'm pushing now to.
When you compare the device for TEER, we know that PASCAL can capture more leaflet than the other device. We know that. Especially PASCAL ACE device can capture more leaflet. We know that because of sometimes one ACE device can be enough for this case.
So now, as you see, I exit from my sheath, and it was elongated, and I make it close shape now. And now I like to direct this PASCAL to above the mitral valve, and to do that we just do clockwise rotation and then push my sheath. Can you repeat it, please?
For example, you used two devices, but two devices.
Yes.
What the difference? You can give some information about us, about the systems.
Okay, this is you see this system, right? This is so. I think we have some differences. The first difference is I think we don't have to do flashing, right? So this is I think important feature of the device. We don't need to do any flashing, right? So no flash, and then we have actually three movements with this device. First, we can do posterior and anterior movement. The second, we can go while pushing this system, we can go lateral, and when we pull medial, and then we can do flexion as well to align with the mitral valve. So we have three movements.
This device has some advantages when you compare with the other device. Actually, this, especially if there are a lot of cordas. If you think to repair the tricuspid lift, and if you think there are a lot of corda, this device is safer than the other device. But this is the need for us in Turkey, you know.
Yeah.
By the time when we used to perform a lot of case, maybe we can compare which one is better for the cases. But no.
Okay, let's go.
To say which one is better for the cases.
It's okay.
We can ask to Dr. Gündüz about his experience because he does a lot of cases with both devices.
I think if you are experienced, both are really suitable. But for one-handle use, PASCAL is really easier to use. It's for beginners. I think Abbott is much better because you know what is happening. You can expect what's happening. Pascal is a little bit more free. So for more experienced users, Pascal might be a little bit better. But I think I'm using 1 week Pascal, 1 week Abbott. So both are nice. And I think both companies learned from each other. You can remember in the beginning, Abbott had not the independently wing gripper. So I would not say one is better than
I think it's okay.
the other.
Yeah.
I think our position is good here. What do you think? We just above the jet, we have a huge jet, and then we just above it. And I think we can cross the valve from here after checking the system. So before that, we have to open the Pascal. Yeah, if they check the fluoro, we are opening. All right. So yeah, and then
Step is
yeah.
the other device, yeah?
Yeah. So now I will check. We have 2 clasps here. I have to see which one is the anterior, which one is the posterior clasp. Yeah. So yeah. So let me see perpendicularity here. Can I see 3D? I want to see first perpendicularity. Yeah. All right. So it's better perpendicularity now. Do you like it, Mike? Counter a little bit, yeah. Okay, okay. So I think perpendicularity is here, and I want to see which one is the posterior. Yeah. Now we have here 2 clasps. One is light green, the other one is dark green. Most of the time, 95% of the time, the light green is anterior clasp. Let's see. Yeah, this is anterior one. And then also we have to check posterior. This is the posterior, right? So we are okay with that. Little bit, yeah, I want to go a little bit anterior, right? Yeah, yeah. So our position is a little bit medial. We have to push a little bit. And I open all system and I push a little bit to have more, yeah, center. I think, yeah, but now I need to go posterior.
Also, you're diving from lateral to medial side. I think maybe you can release some flex.
Yeah. Now I will close the valve, the Pascal, and then I will cross it. Yeah. Okay. Yeah. So we are a little bit lateral. We like to.
You are more lateral.
Yeah, I like to remove it a little bit medial.
Yeah.
Yeah, this is good.
And also anterior, a little anterior. You need to go a little anterior.
All right, we're a little bit low. I want to come a little bit up here. Yeah, okay. Let's open now.
Can we see 3D images again?
3D image, yeah, we will see.
For perpendicularity, yes. Actually, it's looking good now.
I think a little bit posterior I need to go. A little bit. And I'm coming up. Okay, please, yeah, please check the perpendicularity, yeah.
What of that inside
I
of?
think, yeah, we will do a little bit clockwise, a little bit, yeah. Yeah. That looks bad, yeah? I mean, good, yeah?
You aim to implant valve A2, P2, or?
Yes,
Because
exactly.
maybe you need
The mid part.
a little central.
So let's see posterior if it's in. I need to see posterior a little bit.
It's out, yeah.
I will go a little bit posterior. Yeah, I think it's better now. Yeah. Is it folded? No. I'll go a little bit down. Yeah. We have the posterior here. I'm coming a little bit up. Mike, what do you think for anterior? Posterior, I'm sure I'm okay, but how about the posterior?
A little counterclock, maybe.
Or some medial.
And to
See?
lateral. You need to go a little lateral.
Medial.
Okay. So I'm coming a little bit up. I think we have both leaflets nicely.
Out of that inside of, well,
I'm
Simon,
coming up, guys, a little bit.
independent grasping, your strategy.
No, I don't think we need it, Hussein, because we have a nice long two leaflets here. I don't think we need it.
after grasping, they will do.
Yeah. Mike, what do you think?
Because the posterior, I'm not sure if it's buckling a little bit.
Okay,
or,
so first, yeah, okay, let's do.
or if you want to come down a little bit to see the posterior better before you.
Yeah, I clasp anterior now.
Okay.
I did.
Then go towards the posterior to maybe go a little bit lower so we can see it better.
So I clasp anterior and I go a little bit down to go more posterior and.
Will you try the independent?
Yeah.
Yeah, first we clasp anterior. That's my posterior is on now. Yeah.
Yeah, you can clasp.
So I think
Close
You
it
can
very
close now.
close it very slowly.
It's not inside.
slowly.
We have to see.
No,
We're not
it's
sure.
inside,
We're not
inside.
sure either. Yeah, posterior is out. Yeah, posterior is out. So we have to open. Posterior is out. So we can raise the clasps and go for simultaneous clasping. So raise the clasps. Yeah. Okay, let's check. We've rotated.
Orient device again.
So
Look
let's
at
see the
Yeah.
particular trees I like to have clockwise.
Okay,
I
that's
think,
good.
Yeah, this is good.
How many size have this Pascal?
It's a P10.
Professor Ömer, we have, I think,
It's the
somehow
ace- it's the
auto-hugger.
ace
Maybe you can
device.
fix it and then you can catch the leaflet.
Posterior is above us. Oh, it's okay. Good.
Anterior
Okay.
Anterior.
over than posterior.
Okay.
For example, you have to catch the separately or simultaneously. Has some.
One second, because it's rotating.
Pascal.
Michael, I can't hear you well, Michael.
I think the Pascal is rotating. One second, we'll check perpendicularity once more. Yeah, it's slightly clocked at this point.
Little
We
bit
need to
clockwise.
counterclock it a little bit. Counterclock a little bit.
Yeah?
Yes, very good. Okay.
All right.
Okay, let's see.
Okay.
Michael, is posterior okay, you think?
No, posterior is out.
No.
There's a folding for posterior.
Yeah, it's buckling. It's now the
No,
device is
anterior is out
the
now.
device is rotating. One second, please. We rotate it again.
You want to see 3D?
Yes.
Taking breath can help.
Yeah, 1 second.
Or decreasing tidal volume.
What do you suggest?
Okay. Okay.
We can do, but it will.
Biplane.
So. Anterior. I have to go to the anterior because anterior is really out. Yeah.
What do you think about aorta hugging? No.
Okay, so posterior is on. Anterior is also on.
You're right, Hakan. We are a little bit hugging aorta.
You have a little aorta hugging. Maybe you can.
Yeah.
So both leaflets are on.
I'm doing a little bit flex of the guiding. I need to go a little bit more posterior here.
Okay, we have to check the clocking 1 second.
Okay, yeah, let's see the perpendicularity. This is always, we have to check, which is not bad here.
You're a bit clocked a little bit. You have to.
You would like to try the independently to grasp the leaflet. Maybe you need to start with the posterior leaflet because the posterior leaflet is not
A
long.
little bit clockwise, huh? Counterclockwise.
Yeah, okay. Yep.
Okay.
Very good. Yes.
Posterior is good, and how about anterior?
Not good in anterior.
Come slightly lower.
Let's do
Yeah, you have to.
posterior first.
Come. Now anterior is
What
on.
do you think? Anterior is good, yeah?
Okay, both are on, but you have
Both
to come
are on.
higher up a little bit. Higher
Yeah,
up.
okay.
Higher up.
Let's do clasp here because anterior also good.
They are looking good now.
Yeah. Yeah, okay. Go down.
Okay.
Clasp down and then slowly closing.
You grasped both, I think.
Yeah, it looks right. So
It's a nice reduction. I think we should optimize the posterior leaflet a little bit and reassess the color afterwards.
okay. I release posterior grasps. Anterior is in place, so I like to go a little bit more posterior
See it.
and I close.
Yeah, go ahead.
Yeah. Okay. So we didn't release anterior clasp, only posterior, and we moved a little bit posterior. And then let's see, but it's bigger than before, huh?
No, it's it's definitely a reduction in the degree of MR, but we still have a jet in the medial side of things, a very small lateral jet. So maybe we can reposition this device a bit more medial. And then depending, we can see if we can put a second device lateral, depending if we need to.
But I think, guys, we have to decide, if we do second clip or not here. What do you suggest? I think we have, this reduction is not enough to me. What do you think?
You have a medial jet. Maybe you need to go a little to medial.
But also we have a little bit smaller lateral jet too. So if we are okay here to put the second one to medial, or we can little bit come lateral.
You have a big jet.
I think both sides we have actually.
Let's take a look and see how we grasp the leaflets, if we're symmetric or not, if there's any distortion of the valve.
Okay. So that's important too.
I think it looks nicely symmetric. It doesn't look like there's anything.
I think there is no distortion.
No distortion. Looks nicely symmetric. And the jet is coming just from mostly from the medial side. Okay. So I think we can reposition this device a little bit more medial, and then go with see what happens, and go with the second device depending, because although we decrease the MR from torrential to, I would say, moderate, we could possibly even do better than this with this first device.
Okay.
So, okay. So let's aim for a little bit more medial this time. You see where the color is. Okay. Yeah.
Mark, what do you think?
Well, I think position-wise, there is still significant color from some. You could try going a little bit more, slightly more medial as possible, and then we'll assess perpendicularity and go for grasping.
A little medial.
Okay, that's better. That's good. I think that's better. Okay, so let's come a little bit closer to the valve, and we'll go 3D and see how we look on 3D. Let's see how we look.
I think perpendicularity is good also.
Okay. Perpendicularity looks good. Okay, so we could try with that, and let's go biplane again. So okay.
Posterior.
You're above the valve.
We lost the posterior.
Okay, careful now. Well, let's recheck the coaxiality and perpendicularity. 1 second. Yeah. I think you could move slightly more medial by flexing your steerable.
Go to a little more to medial. You are now in A2, P2.
Okay, let's go biplane again and see how we are looking here. Let's change our angles a little bit. Okay, we're not open to 180. We're open to 120, correct? The device. We want open to 180. Okay. Let me check perpendicularity once more. 1 second.
Still same.
Still the same. Okay. Okay. Okay.
Maybe there's a tending for posterior leaflet, tending for folding, because it's not long. Maybe you should try it independently, before posterior than to anterior.
I think depends on the imaging
I think
plane.
a better position.
We are not coaxial to the
Posterior is buckled a little bit. It's outside. Anterior is on nicely. You have to go. Okay, let's get the posterior nicely on the device. So yeah. Anterior is nicely on. Posterior is close.
I think posterior is not bad. Should I go a little more posterior than here?
Yeah, it has to come nicely on the device. It's try to scoop it from below, to come a little bit lower and scoop it from below the posterior leaflet as possible. Okay, posterior seems to be coming in.
Now we turn to Dursun Gündüz, mitral clip stepwise.
Yeah.
Then we turn to you, okay?
Okay, we just grasp here. Yeah, let's see the result, and then you can go. Yeah.
Okay, see you. Yes. Ömer, hello, Ömer.
Merhaba, merhaba. Can we show the previous?
Yes.
So, yeah, we implanted one clip,
And
and
you began to medial.
yeah, exactly. And then we have
Yeah.
Okay,
now we are
so
ready for second clip.
so here's the first device. It's the PASCAL ACE, regular PASCAL in the medial side. We optimized here. We repositioned. Let's see, 1 second. Okay, so this is our sort of.
You hear the mic? Yes.
So
Michael.
can you hear as well?
Can you hear the Michael?
Yeah.
Okay.
Very well.
Go ahead.
So
go
here
ahead.
is our clasping attempt here at the medial side of A2P2, and optimizing our posterior leaflet, and then closing the device. We have eliminated the medial part of the regurgitation. We still have central regurgitation. We were happy with leaflet insertion and residual gradient at 2 millimeters of mercury, and we released this device. And then we're planning with the second device, a PASCAL ACE this time, to supplement the result we have from the first device. And here we are right now over the valve with the second device, positioning it in biplane imaging and 3D. So we need to
So now we are about
correct
to do a second clip.
Yeah, we're going to do a second device next to the first one.
What was the gradient after the first clip?
It was 2.
2.
No, mean gradient.
Yes,
Okay.
mean gradient was 2. It was
Because
very
it's
acceptable.
Large atrium and large annulus.
So we need to clock the device slightly. Okay. Okay. Okay, we'll work with this for now. We'll go biplane imaging. And then we're nicely close to the other one.
Yeah.
Very good. So let's look at the...
I think we can cross the wall now.
Yeah, we have to cross as closed.
Yeah.
Careful not to interact with the first device.
So are you okay? Shall I go down?
Yes, you can go ahead, but very nice. You can open the device now. And then we'll check perpendicularity.
So I think we are in good.
Okay.
Your position is very good.
Let's see the perpendicularity, please.
Yes,
Mark.
immediately.
Where are
Yes. So perpendicularity is here. We need to counterclock this device. Yes.
Yeah. A little bit more, yeah.
That's
good.
That's very good. Yeah.
Yeah, and yes, fluoroscopy it looks.
Okay.
I think very.
We could come slightly closer
nice.
to the other device when we're close, and we'll see that. Okay. So here we are. 1 second. Let me just fix this image. Oh, it's 90 degrees. 1 second. Let me fix this image. 1 second.
As you said, we have to have a good imager, but also every time we need to use the fluoroscopy to look at the parallel or not, the clips.
Especially for the second clip, you're right, Hakan.
Okay, let's look at the color here for a second. There's color between the devices, so that means that there is a little bit of room to go closer as possible. If we could just very gently move a bit closer to the other one. Okay, let's stop there and let's do a 3D reassess perpendicularity once more.
Yeah.
Make sure we're okay there. It looks very decent.
Stays same.
Okay. And then we'll go with, let's clean up the image a little bit, and we can go for grasping. Okay.
I think both are sitting very well.
Okay, come higher up slightly. Sorry. Okay, come higher up slightly, a little bit more. I think you can grasp them anytime you like.
Okay.
Yeah, clasp. Yeah, and then close, yeah?
Close slowly and release your tension. And release tension, please.
Yeah.
Okay.
Yeah.
I think it's looks like a good result with one.
I think we have a good result. Yeah.
Very good result.
Okay.
Yeah.
We'll check a gradient for a second.
Let's see this gradient, which is important here.
Okay.
So for the second clip, I think 5 is acceptable.
Yeah,
You know?
as long as we don't have significant MR. Okay.
Yeah, I think, and then both clip are very close.
Yeah.
So I don't think we could do better than this. What do you think? To have lower gradient.
Let's look at leaflet insertion for a second. Yeah, posterior leaflet.
Actually, after second clip, I wouldn't expect less than 4.5 gradient.
Yeah. Leaflet
What do you think?
Okay.
Can you calculate mitral valve area?
Yeah, okay. Can
No.
you do that, Michael?
Well, in order to calculate mitral valve area, you have to do 3D and planimeter both orifices. So that's a little bit labor intensive. We can try doing that, but in practice we don't we don't routinely do that. And pressure half-time method doesn't apply here. If you want to, I can try and do a planimetry of both leaflets, but it's going to be a bit of take some time to do that.
Patient has atrial fibrillation, I think.
No, sinus rhythm.
No, sinus.
This device here.
Yeah. Let's take a look and see what the biplane looks like again. Okay. Yeah, leaflet insertion seems to be very good. Let's take a look at the clasping sequence once more, so we can verify a good leaflet insertion. 1 second, please. Yeah, here's the clasping sequence where we have, yeah, the next one will be the one. Dropping of the clasps. We see the posterior leaflet resting nicely on the device all the way into the apex. Anterior leaflet all the way in as well. I think it's a good clasp, and we could release this device if we're happy with this result as a residual MR.
I think, yeah, we can release because you have been with a bit timing issue. Let's release it, yeah.
Excellent result, I think.
Two clips sit together very well. What do you think?
Final result with overall from torrential MR to mild MR.
I think we have a good result here after having this huge MR. With T clip, we don't have that much gradient,
Okay.
and we are happy about the result.
Okay. So you want to remove your steerable catheter?
Yes,
Congratulations.
let's remove it.
Good result. We will turn to Tavi. Congratulations.
Yeah, thank you very much.